You're listening to Psych with Mike, and the most important way to support the show is to find us on YouTube and hit that subscribe button. So no matter how you listen to Psych with Mike, find us on YouTube, smash the subscribe button, and we really appreciate it. Now, here's Psych with Mike. Welcome into the Psych with Mike and Brett Library. This is Dr. Michael Mahan.
And I'm Brett Newcomb.
So today we are going to talk about something. First off, can I start by asking you a question?
Sure.
And I didn't tell you I was going to do this, and so obviously, I hope you're not off put by this. But if you had to guess, how many discrete diagnoses do you think are contained in the DSM-5-TR, which is the most recent version of the Diagnostic and Statistical Manual for the Social Sciences?
Well, that'd be difficult for me for a couple of reasons. I'll hazard a guess, but they keep reworking that and changing the definitions and descriptions and from as a response to two different agendas. One agenda is clarification.
Right.
Can they become more clinically precise under the belief that an accurate diagnostic label then tells all the professionals engaged what you're dealing with and their commonalities of treatment or answers or what have you that can help people get better. The other is it's a game that the insurance company plays about, well, we won't cover this anymore because too many people are being diagnosed with this, so it's a loose category, it's sloppy. Tighten it up and we'll cover this description of it. So every 4 or 5 years, they try to come up with a revision of the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, which is the Bible of all the labels. Now, there's the ICD, which is what physicians use, but subsumes that. So
the ICD is in version 10. That's the International Classification of Diagnoses, and that is essentially worldwide. So the WHO uses that, Europe uses that, and the United States use that. So the DSM-5-TR actually, what they're doing is they are making those diagnostic codes universal, so that the DSM code is the same as the ICD-10
but
code.
they're changing them.
Yeah.
They're things they used to have a label for. They say, well, now we'll move that into this category and get subsumed into a different description. So we don't cover that anymore. But if you come up with this precise delineation, we'll cover that. So clinicians who are out there trying to help their clients get reimbursed for insurance payments will have to learn the new descriptors.
Right.
Okay, have you had nightmares 3 out of the last 5 days? Have you had stomach pains 12 of the last 15 months? So if you've had all these things, you can go down as 209, 3, 4, 7, 5, 2. What does that mean? Well, it means shit's happening.
Right.
That's happening in my life.
So how many?
527.
No. 73.
Okay.
So there are 73 diagnoses that are contained in the DSM-5-TR, and if you are out there and you're an expert, and you have some, you say, oh no, it's 75. There's some discrepancy in some of those.
Fingers are crossed.
But it's more than 70.
Yeah.
And of those 70, how many do you think represent the overwhelming majority of psychiatric diagnoses or psychological diagnoses?
8.
15.
15.
So the point being that there's this broad understanding of what represents mental disorders, and then we have this little bitty tiny subset that are used routinely, specifically because either A, people don't feel confident in being able to diagnose other perhaps more intense disorders. B, they don't want to give somebody a label that might have some kind of impact on them as they get older because their medical record is going to follow them.
The reflection of that.
Right.
Yeah.
And C, just as you said, insurance companies only are going to pay for what the insurance companies designate they're going to pay. Right.
Yeah.
I mean, you look at the pharmacopoeia of an insurance company, and they have different tiers of drugs that they'll cover, and there might be a drug that your doctor prescribes to you, but your insurance company says, "Oh no, we won't cover that unless you use this other thing first." It's ridiculous.
Yeah.
It's crazy.
And who's making the decision? Not your doctor.
Right.
But some clerk looking at a computer program.
And the insurance companies aren't doing that off of what is scientifically researchable and ethical. They're doing it off actuary tables.
Yeah.
What's going to make us the most money?
Right.
Yeah.
Yeah. That's the way it works.
So we wanted to start to talk about some of those diagnoses that maybe fall through the cracks that clinicians who are working today might not be as familiar with or might not feel as comfortable with, but are represented in the DSM, and to encourage people to look at the DSM more robustly and, think about how you make a good differential diagnosis for your client.
Oh, I'm laughing because, you and I went through courses 20, 30 years ago where we were taught these things. Here are the categories.
Right.
And we want to make a multi-axial diagnosis. You want to make a diagnosis on 5 different axis points. So axis 1 basically consists of traits, things that are causing an imbalance in your life, but it doesn't subsume your whole life.
So axis 1 originally was organic disorders that appear in childhood.
Okay. And so we would look, and then they had, in addition to the Axis 1 codes, they had what they call V codes, which were their own little subset that insurance would cover if you had a particular description or definition that they would accept. But as quickly as that became a flooded category of diagnoses, then the insurance company would come back and say, well, for instance, there used to be a V code called mother-child problem.
Right.
So if you had a family come in and a teenage girl and the daughter and the mom were having fights every day about makeup and school and clothes and helping with chores around the house or bedtime or whatever, and so that you say, I'm going to see this couple of people, these 2 people, or this whole family, and I'm going to try to work out a better rhythm and less painful, disruptive thing. The insurance company would pay for that for a while. Then after a few years, they said, no, we're not going to cover that anymore.
And
why? Has it gone away? Well, no, it's too many people being labeled with that.
Relationship issues were a V code.
Yes,
so if you did couples counseling, that was a V code.
Yeah.
And so some insurance companies might pay for that, some might not. So then as a clinician, you're stuck with, do I diagnose these people with an anxiety disorder so the insurance company will pay and then see them for couples therapy?
So it's like the dog chasing his tail.
Yeah.
The insurance companies are always saying, well, we need to make more money, so we can't cover this anymore. It doesn't make sense. And besides, it's just not scientifically precise and replicable.
Right.
So the clinicians are like, well, damn, how am I going to get people to come see me if they can't get paid for that? So how do we move now legitimately and ethically? So one of the additional things that had to happen is that you had to be trained in your clinical training to recognize that the client in front of you is not the diagnosis. And you have to teach the client to know that. I have depression. I'm not depressed. I have suicidal ideation. I'm not suicidal. I have rage issues. I'm not rageful. And then you work on those subtle distinctions. How can we impact the level of depression that is limiting your life? How can we understand where it comes from? How can we find strategies for limiting it and reducing it? And hopefully the insurance company will pay. And so the insurance would say, we'll pay for depression, especially if they're flirting with suicide. We'll give you 14 sessions in a 3-month window. And that's all we'll pay for. So get them better, because you should be able to. Our computer model says that's all you need. So then when that time frame ended, if you had seen them more because they had a couple mini crises, and so you saw them twice, 3 weeks, and you'd overrun your 14 sessions, they would say, well, we're only going to pay you for 14. The rest of it was free work. I know it was necessary and important, and you probably saved their life, but you know what? Not paying you a dime. So the games get played, and the professionals then also developed subsets of arguments among themselves. What's your credential? Well, I'm an LPC. I'm a licensed professional counselor. The law in the state of Missouri, the law in all over the country says I can make these diagnoses. Well, yes, you can, just because it's legal, but you don't know crap.
Right.
I have a doctorate in psychology. I know more. My diagnosis is more valid than yours. And then in the next room, there's a physician sitting there going, whoa, wait a minute, whoa, you're a doctorate in psychology? I'm a medical doctor.
Right.
I know more than you. I'm a psychiatrist. And so as you go up the chain, we were taught, try to always give the most ethically justifiable, least severe diagnosis. So for your work, me working with you as a client coming to my office as an LPC, I want to give you the most bland, encompassing, but accurate, ethically accurate descriptor, label. And then I have to remember, you are not the label. This is just for description for other therapists to know what we're talking about and for the insurance to decide if it's going to pay. But I'm sitting here talking to you, and what I don't want to do is say to you, oh, here's your diagnostic label. This is what we're dealing with. Because you then can use that as an excuse. They used to do that with IQ scores. They would always tell you, don't tell somebody their IQ score. If you give them a specific number, then they use it to fail on either end of the spectrum. One to say, oh, I can't take algebra because I only have an IQ of 78. Or one to say, I don't need to study algebra. I've got an IQ of 95. And so they'd say, don't do it. You know, give them a range, give them a spectrum. You're in the top tier. You're in the plus normal average. Same thing happened with these diagnostic labels. So we were taught, Yalom made the big point, always say, you are not the diagnosis. I have to see you as a person. You're a person with this issue. Let's see how this issue complicates your life. Let's find strategies for uncomplicating it. But in the meantime, then we have to decide, are we going to play the insurance game? And are you going to get third-party reimbursement? Because now I do not know a single professional that takes insurance reimbursement. They will facilitate the paperwork so that you can get the reimbursement after you dance with your insurance company. But they don't do that anymore. When I first started practicing 37 years ago, we hired 2 or 3 secretaries in the office just to handle communications with the insurance company. I mean, so we had to come up with enough money to pay our bills
and
but
pay
also
the
pay
salary.
their bills. And we were games with the insurance company where they'd say, well, you didn't fill in line 14, so we're going to reject this claim. And that gives us an additional 30 days to consider the claim. So they would roll back and roll back and roll back. They'd sometimes reject 2 or 3 times over a technical thing with the paperwork and never really look at the issue at all. But they'd stretch out 6 months before paying your bill.
If they paid, and then they might pay part of it and say, okay, well, you know, we'll resolve this by giving you 75% of what you billed for and call it even.
Or they would say, if you're on our insurance panel, where companies hire our insurance to protect their employees, if you are, say, Anheuser-Busch, a big company here in St. Louis, we provide insurance for Anheuser-Busch. We have a capitation contract with them. The company of Anheuser-Busch, will pay us $1 million a year to cover the insurance for all of their staff in St. Louis, which means
we're incentivized to keep you out of that insurance pool, not using your benefit.
And what I'll say to you, the clinician, is we got 30,000 employees in the St. Louis area. We'll populate your office, but you can't charge your normal fee. You normally charge $100 an hour. We'll give you $70, but we'll make sure you have at least 15 clients a week. So to guarantee yourself that level of income, will you sign our contract? And if you sign our contract, that means we have control over the number of sessions, the frequency of sessions, and some of the methodologies that you use in treatment that aren't based on any clinical training that we have. They're based on our computer models. So the therapist then is trying to ask himself, who am I working for? Am I working for Anheuser-Busch? Am I working for Joe Smith? Or am I working for XYZ Insurance Company? Or ABC Pharmacology Company? So training is complicated and required, and licensure is complicated and required. So you come back to, well, okay, so then you got to have standards. And the standards then are defined as the DSM or the DSM-TR. So TR.
So just so people are aware, you had DSM-1, DSM-2, DSM-3, then you had DSM-4, then you had DSM-4-TR, which is text review. That just means every 5 years, the people who publish the DSM, they revise the literature that's being reviewed so that it's never older than 5 years. So then after the DSM-4-TR, you have DSM-5. And then now you have the DSM-5-TR. So when people hear that TR suffix, that just means text review. So it's the same. They don't add or subtract generally. categories when they make those kinds of changes. They just change out some of the literature that's being reviewed.
So that's like when school districts or communities re-edit and republish
a test
old
book.
classics.
Yeah, yeah.
Here's Mark Twain, Huckleberry Finn. Well, it's got some words in it that we don't use anymore, we don't accept anymore. So we've edited, there are newer versions of Huckleberry Finn that don't use the phrase nigger Jim because it's such an offensive concept in today's modern culture. So school districts are teaching Huckleberry Finn when they talk about Negro Jim or just Jim, but they don't say nigger Jim because it's not acceptable anymore. But Mark Twain wrote it, Samuel Clemens wrote it, it's part of the original script.
Right.
And you can find old versions of it, and purists will say that reads better, but the politically correct people will say you can't do that anymore.
And this is probably beyond the scope of our conversation.
Nothing.
I don't know, how do you feel about that? Do you think that those kinds of updates should happen, or do you think that it should, are you a purist and you say, oh, it should be left in its original form?
If we're talking about a work of fiction, I think it should be left in its original form. If we're talking about scientific research-based derivatives, what's the newest information?
Yeah, okay. Yeah, I think I agree with that.
Okay.
Yeah. So what we get to then is this place where the clinician ends up being comfortable with a handful of diagnoses, which they then continue to regurgitate, and I feel like may not always look at what would be the maybe a better explanation or a better diagnosis for an individual client. Do you agree that you can get locked into that? You can just use adjustment disorder or anxiety disorder or general depressive disorder.
Absolutely, I think you can. I think it's like the law of the hammer. If you give a 3-year-old a hammer, everything is a nail.
Right.
And so when therapists get successful and comfortable in dealing with eating disorders, they specialize in eating disorders, then that's the predominant thing that they look for. And their treatment strategies are aimed at that issue. If something else is going on, sexual abuse, well, that may not be part of what we get to.
So then what you end up with is a clinician who is pigeonholing the client rather than the client representing a spectrum of a constellation, is what they call it in the literature, of symptoms that fits a specific diagnosis. So we're encouraging people, we're going to do a series of these, and we're encouraging people to start to think more robustly about how they use this tool, which is the DSM. Go ahead.
Or how it's used on them, for them.
Well, yes, absolutely.
Have we switched from I have an eating disorder to I have a body dysmorphic disorder? What would be the distinction?
Well, so body dysmorphia is actually the categorization under which transgender falls. And so there's a big deal now in psychology in general, where people say, should we label people who are transgendered? Then there's a whole nother organization that says, hey, wait a minute.
Then it says they're flawed in some significant way.
Exactly.
It's not just a natural condition.
No, there's a connotation that's associated with that. But then there's another group in the transgender community that says, no, you got to leave it in because otherwise we can't get treated. And so that's the rub is,
is it medicine, psychology, law, politics, religion? Who drives the bus?
Exactly.
And it depends on which school
it depends
of thought
on
you belong to.
because there's a lot of people in the transgender community says get body dysmorphia out of the DSM, just like they got homosexuality out of the DSM. The homosexuality was in the DSM-3 as a pathology. It no longer appears because that's no longer seen as pathologic. So eventually, my guess is
just immoral.
Yes. Well, yes. That transgender will eventually go through the same evolution, but then there's another part of the community that says, but then how do we access treatment if it's no longer a diagnosable condition?
Well, that's one of the problems that politicians are running into right now because the state of Tennessee, just in the last week, they've gone to trial. They have laws that say it's illegal to do transgender interventions, hormone interventions, treatments for children, teenagers up to the age of 18. However, if you are a teenager, 16 or 17, who's having hormonal imbalances that are affecting your maturation and development appropriately, those exact same treatments are legitimate.
Right.
But not if they're given for the reason
Right.
of what we call gender identity.
Right.
But if they're just given for the hormonal balances, well, then that's okay. So then you get, so the Supreme Court is juggling those set of juggling balls right now, trying to decide where they're going to land on that. So what is it? Because it's,
Well, they ruled Friday.
oh, I didn't know that.
Yeah, and they supported the law.
Okay. So you can make those distinctions on the basis of the reason for the treatment
But-
being socio-political.
But now the question is
But
going to
not
be:
medical.
Are there going to be medical doctors who are going to fudge the diagnosis to say this is a medical issue,
You know-
so that I know they're going to be?
I bet there are.
Yeah, absolutely, they're going to
Say
be.
that.
And so that's the context
Because
of
as much as they're doing medicine, they're playing the game. How are they going to get paid? They're not going to get paid.
Right.
How are they going to do their research? They can't do the research. They
Right.
can't do the research on LSD because the politician said, we don't think that's legitimate. So Timothy Leary's still out there in nowhere.
Timothy Leary is. The legacy lives on.
Ketamine.
And that's a whole nother thing we could unpack, is the how that all went down, and that's for a future
A different trip.
different trip. Yes, very good. So if you are a clinician, go ahead.
No, I was going to summarize it, but you're doing it, so go ahead.
So if you're a clinician out there and you have questions about diagnosing or about anything having to do with the DSM, please send those to psychwithmike.com. If you are a client and you have questions about that, please send those to psychwithmike.com. We are not official individuals who represent the AMA, APA, or any other accrediting organization, but we will we would be more than happy to give you our opinion.
For what it's worth.
For what it's worth.
And my opinion is always going to be, pay attention to the person in the room. The labeling, the diagnostic labeling matters to a degree, but the person matters more. You have to see the person, not the diagnosis.
Absolutely. The music that appears in Psych with Mike and Brett is written and performed by Mr. Benjamin DeClue, and as always, if it's Friday, it's Psych with Mike and Brett.
This is what I had to figure out. How do I have the timer and the article?
But you did it.
I did figure it out, yeah, because I'm technologically adept. I'm adepter than I once was.
You're a debtor.